Research Capacity Building Committee of the Tamil Nadu State chapter of IPS, and it has been successfully running for many months. Thanks to our supporters under the auspice of President Dr. Ross and other executive committee members. On behalf of RCBC committee, I welcome you all. This platform is unique in the sense that it invites eminent psychiatry researchers outside the Tamil Nadu in India, and we take up one of their journals published for discussion, and also we want them to present something of interesting for our PGs and other members of the Tamil Nadu Psychiatric Society to learn from. So in this we have this is the model that we are running successfully, and it is going well with all our members and then postgraduate students. In this, we have shortlisted Dr. Manjunatha, who is working from NIMHANS as a consultant. His particular publication is taken, and then I request Dr. S.R. Nirmal to introduce our guest speaker and then the journal that we have selected from his publication.
Thank you, Dr. Shivanand. I take pleasure to introduce Dr. Narayana Manjunatha. Sir is additional professor of psychiatry at NIMHANS, and he has extensive publications both in national and international journals, more than around 280 publications. And his interests in research areas also vary, mainly focusing on public psychiatry, primary care, and telepsychiatry. Probably with the COVID and things like that, sir has done a lot of publications in telepsychiatry, including both. He's done a lot of innovations in both teaching and advancement in psychiatry, and few of his innovations are in on-consultation training and extended telepsychiatric on-consultation training. And is not only doing tele-consultations, he's also published on tele-aftercare for continuing psychiatric care services. And he's developed a model for clinical schedules in primary care. And he also has area of interest currently he's going to talk about is the rapid testing of intelligence for clinical practice. And his current topic is 1 minute intelligence quotient test. And he's also introduced a lot of new phenomenological terms in psychiatry like delusional procreation syndrome and proxy delusions. And we are waiting. I'm as eager as postgraduates to hear from Dr. Narayana Manjunatha sir directly. And currently, it will be first it will be a presentation of his article by Dr. Kirtana from JIPMA. She will do a detailed presentation of an article, and we will wait for other PGs to ask questions or contribute to it, to which she will answer. If not possible, Dr. Manjunatha sir will answer, and then she'll give a critical appraisal of the current article. I welcome you all once again to the RCBC Journal Club. Hand over to Dr. Kirtana.
Thank you, sir. Myself and Dr. Kirtana, I am postgraduate resident from JIPMAR, and I'll be moving on toward today's Journal Club presentation. So today's journal, it is on the Journal of Psychiatry Research, and it is official scientific publication of the Indian Psychiatric Society, Karnataka chapter. It is an open access and a peer-reviewed journal, and it has both online and print, and it is published quarterly from 2025. So the areas include all aspects of clinical practice and research in psychiatry, including its subspecialties and the allied specialties. The target readers includes the psychiatrist, other medical specialties, and the allied mental health professionals. The editor-in-chief is Dr. Vijay Kumar Habisheta, sir. So moving on to today's methodology article. The article is titled 1 minute intelligence quotient test for point of care grading of the severity of lower intelligence in the patient populations. So the primary author is Dr. Narayana Manjunatha, sir, and the study was conducted in NIMHANS, and it is published in 20th June of 2024. So coming to the introduction, so in psychiatric evaluations, intelligence is assessed during the history taking and the mental status examination. Under MSc, intelligence is assessed in the cognitive function test domain under 4 categories, which include general fund of information, comprehension, arithmetic, and abstract ability. The outcomes are binary, that is either the individual has average or below average intelligence that includes both borderline and the intellectual disabled population. So there is a severity grading for below average or lower intelligence is essential in order to formulate a comprehensive clinical management plan. Currently, for the severity grading, they are referred to formal IQ testing, which is a time-consuming procedure. When we consider the average timeline from the referral to the appointment to the subsequent availability of the reports. Hence, there is a need for an expedited method to assess the severity of lower IQ that will facilitate a prompt execution of comprehensive clinical management during the initial consultation itself without unnecessary delays. So this is specifically important at primary and secondary healthcare centers where formal IQ testing centers are unavailable. So in order to address the need for the rapid and point-of-care clinical assessment for severity of lower intelligence, the 1-minute IQ point-of-care, this test has been formulated, especially for busy clinics to enable a prompt education of patients and their families during the same consultation. So the aim of the study is to compare the clinical concurrence between the 1-minute IQ scores and those from the formally administered IQ test in a case series of around 6 patients. So when we come to learn about this 1-minute IQ test, IQ is an intelligence quotient. It is a numerical representation of individuals' mental age that is related to their actual age. So once we get lower intelligence from history and MSc, we will ask 2 questions to the caregivers. The first question is, compared to the siblings, relatives, or neighbor children, what is the highest age in years in which his or her intelligence has developed? So this gives an idea about their mental age. So if they are uncertain, we can rephrase it in a familiar language and ask about highest abilities like speech, self-care, social interactions, and practical skills in order to gain insights. The second question is to assess their actual age, which we can get from the hospital records or by asking them what is his or her real age in years. So after getting the 2 years, then we use the IQ formula, where that is mental age divided by the actual age into 100 in order to get the IQ. So the actual age should not exceed more than 18 years, even if the age of the individual crosses the 18 years. This is because the mental age will actually increase until 18 years, and after which it stabilizes. The intellectual abilities will stabilize. So even if the individual crosses 18 years, it is the maximum age we can use in actual age calculation is 18 years. So coming to the case series, it is a clinical diagnosis of 6 patients ranged from lower intelligence, like from borderline to mild, moderate, and severe intellectual developmental disorder. The 1-minute IQ scores are recorded during the first and initial consultation, and they are stored in their respective files with a referral for formal IQ testing. The formal IQ testing was done by using Vineland Social Maturity Scale for around 5 patients and Binet-Comet test for around 1 patient. After formal IQ test, the scores from these administered tests, they are gathered in the files for writing this article, so ensuring that the authors remain blinded to these reports. This table shows the comparison of both 1-minute IQ test and the formal IQ test scores. Though the first patient had Binet-Comet test as a formal IQ testing, the rest 5 had Vineland Social Maturity Scale. The visual comparison of scores has been shown that they did not unveil any clinically significant differences. So advantages of this test include the ease of use with a brief 1-minute time frame in the same consultation, and even among illiterate caregivers, so enabling it to integrate with the detailed psychiatric evaluation of the patients. So coming to discussion, it is a 1-minute IQ test is a straightforward, concise, quick, and point-of-care test for assessing the lower IQ severity in the patient population. So this case series, which compared the results from formal IQ test report, they found an acceptable level of clinical concordance between the 2 tests. But the comprehensive analysis of strength and weakness of the 1-minute IQ test is challenging because of lack of point-of-care IQ severity test in the lower IQ populations that has been published in literature till now. The authors suggest using a former classification of mental retardation, classifying it as mild, moderate, and severe as educable, trainable, and dependent MR respectively for counseling purposes to the caregivers. So the strengths of the study include it is innovative and novel point-of-care test for severity grading in lower intelligence patient population with use designed in busy clinics. It enables prompt execution of comprehensive clinical management plans, and it is relevant in primary and secondary healthcare clinics where formal IQ testing centers are not available. So the limitations that I mentioned with the study include it has a smaller sample size, that is a case series of 6 patients. Statistical significance has not been analyzed, and the focus is on the adult patient population alone. So it is designed for lower IQ population, and it is not intended to calculate IQ in groups with average or above average intelligence. So the study has not systematically studied the comorbidities of lower IQ like epilepsy, autism, cerebral palsy, and the other formal educational attainment. So it is not a substitute for the standard IQ test, especially for the legal or certification purposes, with use restricted to only in prompt clinical management. So conclusion, it is a valuable clinical test to swiftly evaluate the severity of lower IQ in both primary and secondary healthcare settings. The strengths include brevity, clinical relevance, point of care use, and suitability in busy clinics. The future research endeavors should include a multicentric systematic study with a larger sample size encompassing both the children and the adult patient population. And it is essential to assess the reliability, validity, acceptability, and ease of administration and concordance between the 1-minute IQ test and the formal IQ test. Thank you.
Thank you, Dr. Kirtana. Thank you all for the active participation. We'll now proceed to the next session, mental distress.